Welcome to another episode of season 2 of Dr. G at the Heart of Healthcare. I have some wonderful experts here so that we can talk about cancer pain and some of the great technology available for patients, and specifically intrathecal therapy and palliative care. We want that to be used more often. So I have two guests here, Dr. Gobi and Chip, and one of you is in Phoenix and the other one is in Michigan, but we're just going to bring it all together and kind of just unpack everything we're talking about today. Good morning.
Good morning.
Morning. Thanks.
Yeah. So let me just introduce you both here before we jump into the technicalities of what we're going to learn today. So Dr. Gobi, tell us about your practice and you know how you came into this field
Yeah, absolutely.
briefly.
Yeah, so our practice, it was founded in 2008 by Dr. Lisa Stearns, who was a big advocate for cancer pain, did a lot of cancer pain, and a lot of intrathecal pump therapy for cancer pain. I met her during my fellowship. I'm a palliative care fellowship trained physician. I met her during my fellowship in 2008, joined the practice soon after, and she has since passed away, but we have continued her vision, the mission of managing cancer pain, and continue to do it to this day. So happy to be here, and thank you for the opportunity.
Yeah, I remember seeing her photo at the conference. Everyone, I met these guys at the annual assembly of Hospice and Palliative Care. Medtronic, really educated us, and we had a good party too. But we really had a good time in Phoenix, and so I remember seeing her photo, and there was a drink created in her honor. So it's wonderful to be continuing her legacy. And so we'll go on the Chip. So tell us how you came into this field. I know you have a background in nursing, and so you have that wonderful medical knowledge to bring to this field. So tell us about you.
I do. Thanks, Dr. G. So I'm a nurse by training, and I started out kind of in a very different realm. I was an OR nurse for a long time, and once I left OR nursing, and I'll be honest, the reason why I left OR nursing, our suite of operating rooms in South Bend, Indiana, was an older suite. It had no windows, and I worked 4 10-hour shifts. And during those 4 10-hour shifts, back-to-back days, especially in the winters here, it was sort of more like living in Alaska than it was in Indiana. I didn't see the sun for 4 days straight, and I thought
Yikes.
I have to get out of this. And I joined the corps of middle managers at that hospital to then be recruited on to Medtronic. And I really haven't looked back. It's been a wonderful career of improving patient access to these transformational therapies. I'm thrilled that you'll
Oh,
have us to talk about it.
yeah, no, that's fantastic. When I talk about this, I actually can remember a question. I don't recall if it's from like the hospice medical director exam or maybe like internal medicine. One question about intrathecal therapy, and I was like, oh my gosh. So the fact that there's something there and we can help facilitate patient access to it and also educating palliative care physicians and hospice agencies about utilizing it, that's exciting, and that's why this podcast is here. So let's jump in. So like I mentioned, we met at the annual assembly and you guys talked about a case of, someone having cancer symptoms, having cancer pain. Folks, when people have cancer, sometimes they get mets, metastases to bone or other areas. And sometimes we can get into crises. I actually have a patient that I'm helping support right now. And I mean, there have been multiple trips to the hospital while on hospice. So having to revoke from hospice because the pain is not controlled. And I know you all mentioned at your table at the conference, folks can have this pump implanted and then way ahead of time. And then when they're on hospice, they can have their pain managed. So I want to help people learn about that, and also not just pain, like nausea and vomiting. When there's intractable nausea and vomiting, they're not able to take things orally. Maybe they don't want to use a Macy catheter, do things rectal, so they have this option. So Dr. Gobi, maybe we can just kind of talk about when people can get this option, and what to ask for or how it works, or just kind of let's jump in. And then before you do that, I want to mention that I have this article here about intrathecal therapy, and I think it's kind of outdated, but it says intrathecal therapy for cancer and non-cancer pain. So I'm sure you guys have more evidence on it. So I'll just kind of give you the floor because I want to really unpack this.
Yeah,
So
absolutely. So yeah, in our clinic, we see patients in all stages of cancer, whether it's early stage, end stage, patients doing well, even survivors. And we offer intrathecal therapy as an option for all of them. I mean, we say that there are a lot of options, but suffering is not an option. And so for patients, I would say that are on doses of oral medications, and often we'll start there with oral meds, and they have a lot of side effects like constipation, nausea, like you had mentioned, or like fatigue, asthenia, sedation. Intrathecal therapy can be a great option. What a pain pump does is it delivers the medication right to the intrathecal space. So if you're swallowing medications, it gets digested, gets through the liver, finally crosses that blood-brain barrier to the spine in intrathecal space. What a pump does is it takes a catheter and puts the medications right where it needs to go. And so it's 100 to 200 times stronger than oral medications. And therefore, we can use much smaller doses with a lot less side effects long term for a patient. So patients that are on whatever dose of medication, it could be low doses, but they have side effects, a pump is a great option. For a patient who can't keep anything down due to nausea, vomiting, a pump is a great option. And I'd even say patients where we're getting to higher and higher doses, but their pain is not controlled or managed and they're still suffering, a pump is a great option.
and Chip, what are your thoughts on that article, that kind of mentioned it and introduced it? How long has this technology been around, if you could tell
Well,
us?
the technology's been around for more than 20 years. Dr. Tom Smith at VCU Massey at the time published in 2002 and talked about IT therapy from a few different aspects. That the two most important endpoints were reduction in overall pain and reduction of side effects. But then there have been articles as recently as 2022 where Dr. Parashad just reviewed a number of articles. Dr. Stearns published a number of things talking about the real world evidence of intrathecal opiates and the economic savings both to the patient and to the system of employing this therapy. And then also in this decade, Dr. Sint published on the reduction of systemic opioids. As patients get to this, they can move farther and farther away from those drugs that are most likely to cause side effects. So there's a lot of data in this realm to support the use of this therapy from a number of different respects.
And Dr. Gobi, any thoughts on this article? Because again, I not every layperson would be able to navigate PubMed, but maybe they're going to look at the abstract and kind of say, "Oh, okay." Maybe you can enlighten them more on: is this a medical procedure? Is this something they have to be hospitalized for to have this implanted? How does that relate to this article here?
Yeah, excellent. I'll talk a little bit about the evidence first and then talk about the procedure itself next. Like that was this article and even actually subsequent articles like that intrathecal therapy does improve pain scores. Like there's good evidence and good data that it does improve pain. But in cancer, it's really important not only to improve pain, but to improve function. And so there were actual, like some of the more recent studies have shown not only pain relief, but improvement in function. So patients are able to do more, they're able to live their life more effectively. And honestly, from a cancer treatment standpoint, there's this thing called the ECOG score for oncologists, and the better a patient's function, the more likely they can continue with treatment and chemotherapy. And so the pump showed improvement in pain scores, improvement in function. One question a lot of palliative care providers then ask me, so I explain that is what about like the side effects? Like, is this a safe procedure, right? So the pump itself is a very minor surgical procedure, Takes about 30 minutes to an hour, depending on the provider doing the procedure and their comfort level. But it's like a port, really. It's underneath the skin, but above the muscle. It's obviously a little bit bigger than a port, and there is a incision in the abdomen and an incision in the back. But again, a very minor procedure, and because no muscle is cut, the recovery time is often days, rather than weeks. And infection rate, the data shows that infection rate, like everyone's like, well, I have infection or nerve injury. What are the risks? And infection rate is about 2%, a little over 2%, which is very similar to a port. Very low risk of any, injuries to the spine, because it's often placed beneath the spinal cord, or where the spinal cord terminates. And there are some other side effects like a spinal headache, very, very rare, maybe 1%. But all these things often can be managed, and most patients after a few days or a week do much better than when they were like before a pump.
That's great, because what you're saying reminds me of so many, patients when they have, a terminal condition. The number one thing they say is, "I just don't wanna be in any pain." They that's the number one fear. And, we're able to manage pain with, the controlled substances, the opioids, and the other medications we use in hospice care and palliative care. But again, that fear is there, and I think that patients having access to things like this, they can feel more control, and they can have their function, like you mentioned. They can avoid being in the hospital, multiple times because they can't manage it at home, or just kind of, I've seen people trying to stockpile their medications, and we know that's a no-no because that's why they're controlled. And so, I think this is good, and it's sustainable to the system, right? Because I know we've had times also where we run out of fentanyl patches. There's a shortage. And so, if there are clinicians listening to this, how can we help build their confidence in learning about this? I'm going to put a link to your website, but I want to move this thing along and advocate for the people who need this.
Right. So this is a reasonably mainstream treatment at this point, in that Medtronic employs 745 people across the U.S. whose job it is to spread the message about this therapy and make sure that patients have access. In addition to you sharing the website, I'll also provide you with an evidence matrix that you're welcome to share on your website that provides more detailed information about a lot of the articles that we've talked about, providing that foundational basis. But I would say if today you think of a patient in your practice who's struggling, or who you could anticipate struggling with pain, and where the most meaningful gains will be made is through the early application of the therapy and the treatment paradigm. But the best thing to do is to connect with a palliative care treater, connect a palliative care treater in the community with an interventional pain treater, because the interventional pain treaters who will help implant the pump, in some instances they'll help manage the pump. In others, as is the case with Dr. Gobi, the palliative care physicians will manage the implanted pump. If you as a palliative care treater would like to do that, Medtronic also has resources where we can provide you what you need, the training, the supplies and such, to be able to do that within your own practice in a simple, safe, and effective way.
That's wonderful. And then I want to keep it on the continuum of care, because a lot of those palliative patients will go on to hospice care, right? And so hospice gave birth to palliative, just so we're clear. So how can we get the hospice agencies engaged? They're managing, a certain amount of, payment from Medicare to manage the patients who come on with a 6-month prognosis. Sometimes they're on for longer than that. How can hospice agencies, maybe some of their liaisons, get engaged in that to catch the people upstream so that we can get them managed before they come to hospice, and then they're already in a crisis and bouncing back and forth to the hospital? That's what I want to facilitate too.
So, Dr. Gobi, I'd love to hear your thoughts on this, but the one thing I want to offer at the very outset is we have testing on morphine inside of this pump, and the morphine is stable within the pump for 180 days. So if you have that 6-month horizon, the number of times that patient need to be refilled is minimal, if any. But Dr. Gobi, you also have worked through this in your community. Can you
Yeah,
speak to that?
absolutely. I would say, and I like your idea, Dr. G, like, because most of our referrals at this point come from oncologists, from hospitals. We don't get as much from a hospice agency, although we work with one very closely. There is a large not-for-profit hospice agency here in Phoenix. And what our relationship often is a patient already has a pain pump and they go on to hospice. They get onto hospice, they have a pump. And what we don't want is, because there's often a reason that patient had a pump placed. And what we don't want is the hospice agency to just neglect the pump and just put them on oral medications, fentanyl patches, um, because like we can adjust the pump and increase the pump. And so communication is key. So we have great communication with this not-for-profit agency. And so we get patients that come into the office still, even while they're on hospice, get their pumps adjusted. We refill the pump while when they come into the office. And then there are times where a patient can't get to us. They're bedbound, they're nearing the end of life, and we go to them. So either they go to a hospice unit, we go to those units, or we do home visits. We go to their home and we adjust the pump at their home or refill the pump at their home. And so it's definitely something that can be managed while the patient is on hospice. We'd love it if our hospices would identify these patients, just like you said though earlier, like before they come on. While this patient is on a very high doses, we could see a lot of symptom burden here. Maybe we should consider putting a pump in prior to them transitioning. I think that's a great idea. We don't do a lot of that here, but that could be like the next step, I feel.
Yeah, I'm not sure, but I think one of the physicians, maybe the president of the Hospice Medical Director Certification Board, is trained to manage it. And so I think if my memory's serving me well, that was a few months ago, but that's what I would like to see. Some of the hospice medical directors who, again, should be, palliative physicians, but sometimes they're pure hospice like me, and just being trained and being competent in this so that again, it's a smooth continuum of care, and we can avoid those hospitalizations and pain crises and all that. We can just make it better for our patients. So I challenge everyone listening to this to let's try to work together, and oncologists, palliative physicians, hospice physicians, hospitalists too. Let's work together to get better solutions for these patients and help our system that's so stressed, right now.
You mentioned hospitalizations, and so there was a cost study published by Dr. Stearns et al. In I think 2019, and it was published in JAMA, Open or Network Open, and so they looked at cost data from around the country, actually nationally. It was I think commercial payer database, and they found that a pain pump, an intrathecal pump, saved costs at 2 months for cancer patients. So there was I believe, a $14,000 savings at 2 months, and I have to look over here for a year, $60,000 savings in a year. So, and a lot of it was recurrent hospitalizations and ER visits for pain. I mean, the idea is that with a pump, like we get them into the office, we adjust that pump, like and the adjustments are much quicker than sometimes medication adjustments, and therefore like at 2 months, again, like there's a significant cost savings. I don't even know where the break even point is, but we imagine it's about a month. So again, because the cost of these hospitalizations can often be so high, and there's, when you ask most patients and families, like they don't want at the end of life, they don't want to be in a hospital for pain. They prefer to be at home and be able to have this all managed as an outpatient, which can be done with a pain pump.
Fantastic. Well, I think we covered it, and if you come across that article, send it, and I'll add it to the show notes. But I think this is a wonderful solution for people. You don't have to fear the pain. It's good to plan ahead and just kind of anticipate the trajectory of your disease, and so that you're not caught by surprise. And I just think that the intrathecal pump can support so many people, and we can just we can just help and save money. Not that we're trying to save money. I know we're clinical focused here, but hopefully the powers that be who make the decisions, who run the cancer centers and all that, they can consider how this could be so life changing for patients and families. So, do you guys have any those closing thoughts? We'll start with you, Chip, and let you finish off, Dr. Gobi.
No, I appreciate you having us on. I really appreciate the interest in this. This is something that I've seen firsthand change the lives of so many people when it's so important for them to be able to live with less pain, to be able to interact with family, to be able to function. It makes such a profound difference for folks, and I'm thrilled that we're doing what we can to provide more access for more appropriate patients.
Yeah, and I agree. I've seen it just personally transform lives. And just real quick, I have in the hospital right now. I saw her. She's got a small bowel obstruction, unfortunately, but her and her sister were saying what a difference. She's 25 years old with metastatic colon cancer, and said like what a difference the pump made. Her sister said like she would cry herself to sleep at night because of the pain, no matter what we did medication wise. But for the first time after the pump, she was able to sleep. She was able to actually live a somewhat normal life. So, just to reiterate what Chip said, it makes such a big difference for patients' lives and their families.
Yeah, well, listeners, you saw me take a deep breath. I know these topics are difficult. You mentioned that 25-year-old. The one that I mentioned earlier is like around young like that too,
Hmm.
that had the two pain crisis from pancreatic cancer at a young age. Had another one, small bowel obstruction recently. She's passed on, but again, multiple hospitalizations for that. And if we could have gotten it controlled, they could have had a better quality of life at the end. Or the past few months and years that they've been bouncing back and forth. So, oh, I hope you all feel that in my heart. Everyone listening, please look at these articles we're going to attach here. Thank you to Medtronic for leading the way with this technology, and we hope that this increases access to patients. So, thank you for being here, you two.
Thank you. Thanks for having us.
Thank you so much. Bye bye.
All right. Peace, everyone.